There we are. I think we are live. We are. I'm sorry, I'm technologically illiterate. Carrie Martin, thank you very much for joining us. And I'm sorry that we confused our times a little bit here, but never mind. You are a chartered physiotherapist, with who is a member of the obstetrics gynecology physiotherapy group, and also a member of the BMS. So you spend a lot of time talking about pelvic floors with women who really do need help. Shall we run through some of the most common things that happen when estrogen starts to decline and how that affects the pelvic floor?
Absolutely. So yeah, a real biggie in the menopause. So obviously, the sort of receptors within the pelvic floor, vagina, urethra, bladder, that are estrogen and progesterone receptors. Obviously, as that estrogen decreases in menopause, that affects all of those tissues. So from a pelvic floor perspective, they start to lose collagen and elasticity, so they can't provide as much support to the pelvic organs, and we might also then see some thinning and loss of collagen within those vaginal tissues themselves as well. So we get vaginal atrophy, which might mean that we get that soreness, that dryness, which then obviously can affect how comfortable women feel. It might affect whether they, still enjoy having sex or not based on those tissues. So replacing those tissues with some estrogen is important, and systemic estrogen might not always do the job. So they might need some more sort of kind of creams, moisturizers, topical estrogen to help with that as well.
Yeah, so frontline treatment number one, get that estrogen in there, but that may not necessarily be enough. There are a large group of us who continue on having difficulties, especially with three common things: stress urinary incontinence, the sort of peeing when you sneeze, run, jump, laugh, those kinds of things; urgency, or an overactive bladder, that sort of feeling of like, oh my God, I absolutely have to go now. And then prolapses, they throw another spanner into the works, probably almost literally in a way. So what are those things, and how do they, when you see women coming into your clinic, how is their quality of life affected by those?
Oh, massively. So, I think sort of 1 in 3 women at some point in their lifetime will be affected by, some form of pelvic floor dysfunction. So, like you say, incontinence or prolapse. And, I think it takes women on average about 7 years to seek help for these things. So it affects their quality of life massively. There's embarrassment there. A lot of women don't realize that there's help out there for those conditions either. So I think often it's sort of a put up and shut up, or an expectation that you've reached a certain age, so it's just par for the course, really. But although
that just drives me absolutely batty. That whole, the things about the ads with people sort of buying their absorbent underwear and thinking that if they're going to spend A, they're not cheap, and B, a lifetime of them is not fun. And there is so much that can be done. This is not just a sort of like, oh well, it's my lot in life. There's a lot that can be done. Anyway, I'm sorry, I digress there, because it just
No, I completely agree. It infuriates me as well. The sort of absorbent product company, they do make lots of money really from selling these products, and although they have a place in terms of whilst women are managing these symptoms, they're not the treatment. And all of these conditions and these symptoms that we're going to talk about, they're all really, really common, but they're not normal. I think that's the bit that we kind of need to go away from, is accepting it as normal. It's common, you're not on your own, but not normal. So yes, I mean, stress urinary incontinence, super common. So that's obviously where there's some leakage of urine when we cough, sneeze, laugh, or during activities. So that might be exercising, that might even be during sex. And the leakage might be a little bit, or it could be a lot. So it sort of varies really. And even if it's just a couple of drops and it's not every time, it's still a form of stress urinary incontinence. Urgency, again, that can sort of be varying degrees. So urgency, we would talk about if somebody needed the toilet, and they go from kind of 0 to 100 in terms of that urge. So they're just desperate all the time. They might be going a lot, and that is really life limiting in itself, that constant need for the toilet, that you can't really go anywhere unless you know where the nearest toilet is. You maybe limit the activities that you're going to do because you just don't want to have to go to the toilet. As a result of that, people then maybe don't drink enough. They then dehydrate themselves because they don't want to keep needing to go to the toilet. And the knock-on effect of that increased urgency and increased frequency is maybe not making it to the toilet in time either. So then we've got urge incontinence and we've got leakage from that side of things. And again, that might be a few drops. It might be a whole change of clothes. And prolapse. So, prolapse can happen at any age, but obviously, can be very common with the reduction in that estrogen that we talked about from a menopause perspective. So that's where we're feeling either the bladder, the bowel, or the uterus, or if you've had a hysterectomy, it could be the vaginal vault. And that descends a bit lower into sort of the pelvis than what it would be normally. And because of that, we might feel really uncomfortable. So we might get this heavy, dragging feeling in our vagina. Some people describe a feeling like a tampon is stuck or sitting a bit low. You might get pain in the abdomen or the vagina. You might actually be able to see or feel a bulge. And often if you can see it, it looks a little bit like a plum because you can see that sort of shiny skin from the vaginal wall as it bulges out of the vagina. And some days it might be worse than others. There are some activities that might make it worse. So symptoms will vary. Prolapses can also then affect bladder and bowels. So, again, that might put pressure on the bladder. It might mean that we have that stress incontinence, that increased urgency. It might make it really hard to go. So, we get that need that we need a wee, and then we sit down and it's really difficult to empty. We've got to keep changing position. It might kind of squirt off in funny directions, and it never used to do that before. It might, make it really difficult to empty our bowels, and then we're sort of having to help out with that. So some women might describe that they have to support their perineum just to open their bowels, or they might have to insert a finger vaginally to put pressure on the back wall so that they can push out what they need to empty. So yeah, it can have sort of varying degrees of symptoms for different people.
Yeah, and they're pretty life-changing things to have to do every time you go to the loo, really, aren't they?
Absolutely, yeah.
Yeah. I mean, it takes an awful lot of dignity away in some ways.
Well, it does. And you can understand if women are suffering with these things, why, socially they might retreat a little bit, and why their relationships might also suffer as a result. And, so many women stop having sex based on these symptoms and how it makes them feel, how uncomfortable they are. And, it has a big impact, affects work, whether they're still going out to work or not, or actually whether because of those symptoms they're not able to do so. And exercising, and we all know sort of the positive impacts that exercise has on our mental health. So, if we're suddenly not exercising because of some of these other physical symptoms, then it really does have a big impact on our mental health.
Absolutely. All right, so let's work out what we can do then to fix these things, because that's the most important thing of it, turning things around. And just before I get into that, somebody sent me a message this morning about one of their aged in-laws. My husband is about to come home with a very large barking dog. So if you hear that in a minute, even though I've told him that I'm doing this live, You will understand why. Anyway, I got a message this morning from a woman who was saying that she has a very elderly relative who does have urinary problems, and basically just sort of thinks, oh well, it's too old for me now to do anything. Is that true? Is there ever a point where it is too late to make some form of improvement?
No, not at all. No, it's never too late. The pelvic floor is a group of muscles, like, you know, we have muscles everywhere else in the body. So, you know, we work on strengthening those muscles up. And, you know, if we wanted to do that later on in life, nobody would ever say to us, you know, you can't strengthen up, you can't increase your fitness, you can't make those changes. So no, it absolutely is never too late, really, to strengthen and improve the function of your pelvic floor. So yeah, kind of start as soon as you feel that you can.
Absolutely. So when we start now, people, this is one thing that always drives me batty with people saying, you've got to do your Kegels, and then they sort of sit there saying, I've just got to squeeze my butt cheeks together and all will be well. Are Kegels appropriate for everybody, and how do you do them properly?
So they are. Not everybody has a weak pelvic floor. Some people just need to learn how to work it in the right way, or even learn to relax and release it. So it's always really helpful to have an assessment by, you know, a pelvic floor or pelvic health specialist, so that they can, you know, let you know sort of how your technique is. But ideally, when we're describing, you know, where our pelvic floor is and how we should be activating it, so it's the muscles that go, obviously, kind of from the bottom of our spine right underneath us and insert into the front of our pelvis. So they're keeping our pelvic organs in place. They're also shutting our urethra and our anal sphincters off to stop any wind, wee, poo escaping. So if we imagine we need to do those things, that's often a really good place to start. So imagining that you need a wee, that you need to pass wind, and you're trying to stop those two things from happening. So the squeeze and lift of the muscles should be happening internally. So we should feel it inside our vagina, and we should feel it inside our back passage, inside our anus. So our buttocks should definitely not be squeezing. Our thigh muscles shouldn't. Our abdominals, on a deep level, yes, but actually consciously we shouldn't really be pulling our tummy in. Definitely not holding our breath, no sort of funny faces or lifting shoulders, nothing like that. So actually, when we are efficient at activating our pelvic floor, nobody around us should be able to tell that that's what we're doing. But it can take a lot of practice, and the best position often to try it in, just to start with, is laying down, so that you can relax everything else, concentrate on what you're doing, and obviously we don't have to work quite as hard against gravity. Some people, they use other sort of imagery to try and help them locate their pelvic floor and activate it. So a really good one that I've heard of before, that's worked with quite a lot of my patients, is imagine that you've got a straw up your bottom and you need to suck up through that straw as hard as you can. And it gets, you know, it does get the pelvic floor working. And the other
is going to get my pelvic floor working.
And the other one, which I really love as well, is imagining an octopus. So kind of, you know, inside the vagina, that sort of that lifting movement, that squeezing and lifting. So yeah, people find different things work for them, but ultimately that's what we're trying to feel. And ideally we want to be able to hold that. So we do that squeeze and lift internally, and we want to try and hold that as long as we can, but we're aiming for about 10 seconds. After that 10 seconds, we should be able to let go completely, fully relax those muscles and not hold on, and we'd repeat. So hoping not to get tired, and we'd aim to do up to 10 of those. They're what we call our slow squeezes. And then we do our sort of quick ones, or our fast ones, so where we squeeze and lift, let go, squeeze and lift, let go. So we're basically working the muscles from a slow perspective to help us with that urgency and prolapse. And the quick ones are really what help us with that stress urinary incontinence and that reaction to that increase in intra-abdominal pressure when we cough, we sneeze, we laugh, we move around. The idea is that we would do our slow and our quick ones up to 3 times a day for around 3 to 5 months before we really sort of expect to see some big changes. So we might notice differences happening up to then, but it definitely does take that long to really make a difference to the strength in those muscles. But once we've got it, obviously we've got it, so we need to then maintain it, and to do that we would just want to do our exercises once a day. Doing them laying down obviously is a good place to start, but actually that's not functional. So often our symptoms are not when we're laid down, they're when we're upright, moving, doing things. So we would also want to train the muscles in different positions, you know, go to sitting, standing, and then actually try and incorporate them into movements. And that's a bit trickier. So again, it's really helpful, I think, sometimes to go through those things with, you know, a pelvic health physiotherapist who can sort of guide you on what to do.
Yeah. 2 things out of that. If perchance you haven't done these for years and you do sit there thinking, okay, I'm going to imagine I'm sucking something up through a straw into my bottom, which I am never going to do, and you feel nothing, are there ways then of let's say, okay, I come to you and I go, I am a ball of internal jelly muscle wise. How can you get my muscles actually working? And you mentioned abdominals in there at all. Do they play much of a role as well in helping with stress urinary incontinence?
Yeah, so the really sort of deep abdominal muscles, they do work in conjunction with the pelvic floor, so they should both kind of react together. So it is always helpful to increase your abdominal strength and making sure that you can draw in your abdominals and you're not just always bracing. So that bracing movement sometimes actually increases that pressure more, and it might then mean that we brace and we might push down through our pelvic floor rather than squeezing and lifting. But making sure that our deep tummy muscles are nice and strong, and just our general core you know, is nice and strong can be helpful, because if our muscles are weak around the pelvic floor, it's got a much harder job to do, whereas if we get nice and strong everywhere, then it does have some support.
Yeah. So for the people that don't have any, how do you start them off?
With abdominal strength. So
Well,
again,
more with bottoms, more with the pelvic floor.
More with working pelvic floor. So breathing control would be key to this as well. So again, I think, you know, that sort of laying down position, working on being able to take some nice deep breaths in and out, and we've got that good sort of expansion and stretch of the diaphragm. So sometimes we talk about belly breathing, so inhaling into the belly and then exhaling as that sort of it kind of reduces down. And as you do that, you can then work those deep tummy muscles and the pelvic floor at the same time. So we might draw the tummy in very, very gently, so thinking belly button towards the spine, and then think about trying to do that internal squeeze and lift of pelvic floor. So it's using sort of the diaphragm, the deep tummy muscles, and the pelvic floor. And sometimes if pelvic floor on its own, you know, you find it really hard to find it, activate it, then using that breath, that nice breathing control, and pulling in that tummy gently can help as well.
Brilliant. Now, there are some things that people can use as well if they are mobile, especially if they're exercising or if they're having difficulty, you know, keeping urine in when they want to. Pessaries and things like that. What kinds are there and how useful are they? And are they easy for people to use themselves?
So yeah, there's varying degrees of pessaries out there. So from a kind of an incontinence point of view, there are some which you can use which do help to basically support that urethra and kind of shut off that leakage of urine. So a femia, which I don't know if you can see here. So that inserts just like a tampon would, and the ring at the top basically will then sit against the urethra, and it can stop that leakage of urine. And that's something that you could insert yourself and take out. So you might wear it when you are moving or exercising, as an example, and then you might take it out the rest of the time.
Is it reusable? Because I know there are some on the market that aren't reusable, and I kind of thought, well, that's a shame. So
yeah. So there are some which they do look like tampons, so kind of the contams. This one is, so yeah, there are different ones, but the ephemera is reusable. So yeah, you would just take it out, clean it, you could use it again. I think it's silicone based. But yeah, there are some others out there. The Contrail, the Contam. You obviously you can sort of buy some of these yourself and try them, or you can get fitted for things like the ring pessaries, which some GPs, gynecologists will fit. There are so many different ones out there that I think, you know, if that is something that is worth a try, if, you know, pelvic floor exercises on their own haven't done the job, you know, if you've kind of made any lifestyle changes which have been recommended to you as well, then, you know, it is worth exploring those options, because they can just be temporary solutions that you might, like I say, you know, you manage them yourself, you insert, you take out when you need to, you can still you know, have sex, exercise, do whatever that you need to do, really. But yeah, I think the reusable ones are obviously better for the environment.
yeah, it's a shame. And are there any that say they're sort of relatively permanently, or
Yeah, so
in and out when you need
yeah, so normally, particularly the ring pessaries, so they would be support of prolapse predominantly, but yes, they are put in and you keep them in, and because it's a ring, it means that you can still be sexually active with it in, and it will support normally if it's an anterior, so a bladder prolapse or uterine prolapse, it can be quite successful. There are varying different sizes, so it's about getting the right size and getting the right fit, but those generally stay in.
Yeah. Well, it's good that there are choices there like that, because they're things that you know, options that people really sort of need to know about, and it would be especially useful while you're sort of retraining your bladder. I mean, your pelvic floor muscles. We'll get to retraining bladders in a moment. Other things, you know, there are surgical interventions, aren't there? There are medical interventions. There are things, bulking agents and things like that. Can we avoid those if we do? I suppose it depends on how bad things really are, but how do we know when we have to go further than doing the pelvic floor stuff?
So yeah, they are from like a surgical intervention, definitely the last port of call. I think, you know, medication wise can be useful for things like urgency and overactive bladder, but you know, I think surgical intervention for stress incontinence, yeah, that would be a last port of call. So the NICE guidelines recommend that the first thing you would go through would be supervised pelvic floor training program for, you know, a minimum of 3 months, and that you would make kind of any lifestyle changes that were helpful. And then, you know, if that didn't help, then you could explore, obviously, like you say, things like the pessaries, which you could do alongside pelvic floor training as well. Obviously, surgically, you could have kind of support provided to the urethra. So the colpo suspension surgery is sometimes done, and that you know, it can work. But again, you'd need to make sure that if you went down that road, if you tried everything and you needed to go down the surgical route, that you still had a really nice strong pelvic floor, because you're going to need to protect any kind of surgical repair post-operatively anyway. But I would stress anybody to go down the non-surgical route first, and it is recommended in the healthcare guidelines as the first port of call anyway.
Yeah, but yes, you always. I want to avoid surgery at any cost, really. But maybe that's just me. I prefer to stay away from anything that involves scalpels. Moving then quickly to bladders and overactive bladders and urgency. I mean, I've heard stories of people who literally can't get from their car to the front door. They've actually had to pee on their driveway because of this desperate need to absolutely go now. Other people who, as you were saying before, refuse to leave the house, plan their routes and journeys outside by where the nearest public toilet is. Those kinds of things, they are severe impediments to quality of life. So how do we get around that? What can we do to get over that need of, oh my God, I have to pee right now?
So there's quite a lot that can be done for overactive bladder. It's really quite complex, and different people will find that there are different triggers for them. But obviously, pelvic floor would be, one of the first port of call as well. But bladder retraining is really helpful with an overactive bladder. So that would be kind of learning what some of your triggers are, and learning how to get the bladder to hold on. So it often sort of it gets into that routine of you see things. So you mentioned, kind of the car on the driveway. So key in the door syndrome is a really common one. We're okay. We don't really need the toilet. We get home, we're trying to get the key in the door. We're desperate. So we need to learn then how to, I guess, kind of downgrade the system and get that fight or flight response to simmer down for us. And that helps to kind of switch off those overactive nerves that are making that bladder contract and tell you that it absolutely must empty right this second. So we might want to sort of practice some deep breathing techniques. We might want to try and push up and down onto our toes, or even kind of curling our toes. Some counting, you might count backwards from 100. You might even try and distract yourself by doing some really difficult mathematics in your head. Distraction of any sort is a good idea. Squeezing and lifting your pelvic floor for sort of 10 to 15 seconds, that can sometimes provide enough pressure around the bladder that then that will switch off that need to go as well. And what we would want to do is, if actually that urge we got when we were near a toilet, what we could do is just try and delay it, maybe for a minute, 2 minutes to start with. So we might still take ourselves to the toilet, but we might try and then use those distraction techniques whilst we're around the toilet to try, like I say, to get that bladder to stop feeling sort of so desperate, so urgent, and see if we could hold off for a minute or 2 minutes. And if you then did that for, a number of days, you then could maybe increase that to 5 minutes, to 10 minutes, and the next thing you know, you are obviously you're delaying it, and you're in charge of your bladder and not the other way round.
Speaking of being in charge with the bladder, then, do we actually sometimes put ourselves into this situation by perpetuating bad habits? I know I have a really bad one, and it's every time I go outside, I think, okay, I need to go to the loo before I go out. Most of the time when I don't really need to go to the loo and I'm just going to the shop, I know I'm only going to be half an hour. Do things like that send the wrong signal from our bladder to our brain that it needs to empty more often when it's not full?
Absolutely, yeah. So that's why, if we continue to do those things, obviously not consciously, but the more that we do them, the more those habits set in, and those sort of neuromuscular pathways are in place. So the brain is telling the bladder that it needs to empty when actually it doesn't, and we end up with this kind of sensitivity. So there are some things that we might do that also feed into that. So going to the toilet just in case. So emptying the bladder even when we don't have the signals that we need to go. So it gets used to emptying with much smaller volumes. So then actually it's not able to get really full, because it once we've then got those smaller volumes in, it's telling us that it needs to empty. It's what's really helpful sometimes is when people have an overactive bladder is to do what we call a bladder diary, where you just kind of you keep note of what you're drinking, how often you're going to the toilet, how much fluid is coming out when you go, because some people will find they're so desperate and they get there and it's just a bit of a trickle, there's nothing there, and actually they felt like they were absolutely, you know, full to bursting. So it's really helpful to know, you know, what's happening with that, and also what we're drinking.
People normally excrete when they have a pee. How many mils should there normally be?
So we're probably anything, I guess, between kind of 200 to 400 mils. The first signals that we would get that we need to go to the toilet are normally around about 200 mils, I think. So yeah, we want to kind of make sure that we're getting good volumes and that the bladder isn't just needing to empty.
There's my dog. So a nice full glass full, right?
Yeah, yeah. And sometimes, you know, it might be that we're not drinking the right things at the right times, and that can make a difference. So that's why the bladder diaries are really good, because it might be as simple as, well, actually, you know, you're drinking this large cup of coffee first thing in the morning, and then, you know, you're urgent for the toilet quite a few times, and that's because, you know, caffeine is a bladder irritant, but also concentrated urine is a bladder irritant. So we have that first wee of the day, it's really concentrated, and then, you know, we might not put any water in there, we might just go straight for the caffeine. So then you know, it's irritated and wants to empty. And, you know, there are other things. So, you know, fizzy drinks might do it. Even hot chocolate that has caffeine in, really acidic fruit juices, green tea that has caffeine in. Some people even find peppermint can aggravate. So, you know, they're really common ones, but people will find as an individual there are different things that irritate. Spicy foods, foods high in sort of water content, so watermelon, cucumber, that might do it as well. And medications. So, you know, we take, you know, medications for different things, maybe blood pressure medications. So there are other things that could aggravate. So it's always worth, if you are taking medications, discussing those with your GP to find out if actually, you know, they could be irritating your bladder.
Yeah, that's a very good point. Various interesting treatments. When we think about Botox, we normally think about wrinkle reduction, but sometimes they use Botox in a bladder as well to decrease overactive bladders. How does that work?
So yeah, so it's done surgically. So basically, they'd inject Botox into the bladder wall through the urethra, and yeah. So it would then hopefully help the bladder wall to relax, so that it's not contracting as often. So then it allows the bladder to fill up. We get those larger volumes, we're going less often, and we're not as urgent. So yeah, it then sort of starts to react kind of like a normal bladder, like we would want it to.
And would that actually help with the retraining as well? Because after a period of time, the signals it's sending itself would be telling your brain something different as well. So do they work as an adjunct in a way?
Yeah. So it could do, because yeah, you would get used to those habits again. The bladder would get used to, you know, stretching to its full capacity, the volumes, and just those habits. So you wouldn't have quite as many triggers, I guess, because it's not like oh well, when I see that I need to go. It's, well, when it's full I need to go. So yeah, I think if you've tried bladder retraining on its own, if you've tried, so there are, you know, other medications as well that can be prescribed that help to relax the bladder that you could just take, you know, that might also help with the management of overactive bladder. So if you've tried those, if you've tried bladder retraining, you've cut out bladder irritants, and you've worked on your pelvic floor, and they haven't made a difference, then something like Botox can be, you know, another option. And, you know, it doesn't last forever. So yeah, you're right. You know, the hope would be that if you've then picked up those better habits again, and the bladder's got used to fill into those volumes, that, you know, even if it was to wear off, you would be able to manage that a little bit better.
Yeah. What other things are important for urgency? What other things can help?
Obviously, things like stopping smoking, losing weight if you are overweight, that helps. It puts less pressure and strain on the pelvic floor. Like I say, sort of diet and making sure that that's good and we don't have sort of any irritants within that. If the pelvic floor is strong enough, then it should be able to help to sort of turn that signal off that we need to go to the toilet. So working on your pelvic floor strength, but also working on that ability to let go, because what can often happen with a lot of people with urgency and overactive bladder is I'll assess their pelvic floor and actually it won't be that it's weak. It's actually that it's just really overactive and it's switched on constantly. So they've got a really good 5 out of 5 squeeze and lift, but they get tired quite quickly because what's happening is the muscles are constantly working, and they're not able to sort of let go and release. So then when we need that strength in there, it's just not there. And so working on relaxation is helpful, and that also works for overactive bladder. So I mentioned before about like the deep breathing and the counting. So if we can also try and use some relaxation techniques at home, we might do some mindfulness, some meditating, some stretching, some yoga. That does really help. Just downgrading the whole system and getting the whole system to relax can have a really big difference. There was some research done a while ago now, and I can't remember the specifics of it, but basically what it showed was that when we sort of contract and hold tension within our neck and our shoulder muscles, the same happens within our pelvic floor. So if you know that you are going through a stressful and anxious time and you feel quite tense, the chances are your pelvic floor will be, and your system will be in overdrive. So that's probably going to worsen your overactive bladder and urgency symptoms as well.
God, it's complicated, isn't it? Very, very complicated. And then if we throw in a prolapse as well, how useful can pelvic floor exercises be in perhaps either preventing or not curing, but perhaps maybe slightly alleviating a, oops, hang on, sorry, somebody's trying to call me, go away. Yes, between the dog and the phone. Not curing, but perhaps alleviating a prolapse.
So really useful. And again, in terms of the NICE guidelines, it is the first line treatment. And if we have a nice strong pelvic floor, then we have the support underneath our pelvic organs. So in terms of the symptoms we get with pelvic organ prolapse, it's from the descent and the drop of those organs. So if the pelvic floor is nice and strong and it's sitting nice and high, it can obviously then support the vaginal walls, the bladder, bowel and the uterus. So we would definitely want to start a treatment of pelvic floor strengthening or using the pelvic floor in the right way. So again, assessing what the muscles can do, assessing somebody's technique and getting them to use the pelvic floor in the right way, doing the quick exercises 3 times a day for a minimum of at least 4 months with a prolapse. And we might do that on its own. We might do that alongside something like a pessary that we talked about before. And if we've done it for at least 4 months and there's no change, then it might be that we would explore other options. But actually, for a lot of women, that makes a big difference. And with a prolapse, we are treating symptoms. So prolapse isn't life-threatening or dangerous, but it can be really uncomfortable and life-limiting. So if your symptoms are no longer there and you can exercise, you can go out, your bladder and bowels work as they should, if actually for you your life feels good and your quality is good, but there's if we assessed you there was still a little bulge, that wouldn't matter. It is symptoms. So yeah, pelvic floor training absolutely should be tried first because it can make a really big difference.
Yeah, yeah, because that's so important. You mentioned 3 or 4 months worth of treatment there. Here comes my dog. There she goes. Um, in terms of access, this is the other thing too, because not everybody can afford to go privately. How much help is out there on the NHS? Can you self-refer to a pelvic floor physio? Because I know that there are self-referral systems which I've used, which are fantastic, but I don't think a lot of people know about them. And so are they out there? And if not, what about things like the Squeezy app? What can really help if people don't have deep pockets and can't afford private help?
Yeah, so yeah, the Squeezy app is great. It's a really good tool. And obviously it helps with kind of that exercise adherence, and remembering to do the exercises. So that's always a good thing to try. You can, try and assess your technique yourself. So you can use a mirror, and what you're looking for is basically the perineum, so the body between the vagina and the anus basically lifts in. If you see a bulging, then you're probably pushing down and not actually squeezing and sucking in. So that would be the wrong technique, and you probably would need to get assessed. But yeah, if you can see that lift of the perineum, it's probably going in the right direction. You could insert a finger or a thumb, and you should feel sort of a tightening and a squeezing up around that. In terms of kind of referring yourself into services, it varies from place to place. So different trusts will have different sort of referral pathways. Some you will be able to refer straight in, so it's always worth inquiring and contacting the local physiotherapy department to see if there is a pelvic health physio there that you can just self-refer into. If not, normally you can be referred in by a consultant, so normally consultant gynecologist, which you could get through via your GP. So asking your GP to refer you for your symptoms, and then obviously the gynecologist or urologist, whoever it is that you've seen, can then maybe send you to see the physios that way, and you can then see one on the NHS. The Squeezy app does have a directory, so it has an NHS directory and private, so it will tell you who the closest physiotherapists are in your area, and so then you can sort of explore that as well.
Yeah, the Fiona Evans is saying over here that there's a you can self-refer to a bladder and bowel nurses as well, and local continence services. I guess that depends on where you are as well, I suppose.
Yes, yeah. So yeah, the continence advisory services. So yeah, lots of places do have those as well. So yeah, no, that's a really good point.
Yeah, which would be excellent. So wrapping up, what are your take-home messages apart from obviously if you can get it, your topical vaginal estrogen? What are your take-home messages?
So I think pelvic floor and healthy lifestyle would be top. Do your pelvic floor exercises. We do them for life. We need to keep those muscles nice and strong and working well. Downloading something like Squeezy is helpful. And making sure that you avoid bladder irritants where you can, you avoid constipation where you can. So that's a biggie. I've not mentioned that yet, but from both incontinence and a prolapse point of view, making sure that we're not constipated, bearing down, and we're not drinking loads of fizzy pop, caffeine. We're staying well hydrated, 1.5 to 2 litres of fluid a day, so we don't irritate the bladder with concentrated urine. And don't put up with any symptoms. Whatever it is, somebody else is going through it. Like I say, at least 1 in 3. If you speak to your friends, somebody will tell you that they've got, whether it is just that vaginal dryness, whether it's prolapse, incontinence, they will have something, and you're not on your own, but it is common and not normal, so please don't put up with it.
Yeah, I would imagine that pretty much any woman who's had a child at some stage will have leaked. I would imagine that pretty much every woman over the age of 45 at some stage has the chances of you being alone out there are pretty much zero.
Absolutely.
Yeah. Brilliant. Excellent. Look, thank you so very much for that. So where do people find you should they wish to find you?
So I'm based in Nottingham. Yeah, I work at various different places, but you can find me on Instagram. That's probably the easiest place. So _pelvic _health _physio. And yeah, please drop me a message if you want to chat.
Brilliant, thank you. And also via the Menopause Consortium.
And via the Menopause Consortium, yeah.
Excellent. Thank you so much. I will end this now. And people, remember, if you wish to subscribe to the Menopause Research and Education Fund, where you will find a host of videos like this that are very, very useful on bladders and UTIs and menopause and everything. There's a whole stack of them there. So thank you again, and hopefully we'll speak to you in the future.
Thank you. Bye-bye.
Take care.